Okay, let's continue. You probably all got these announcements anyway already, but just for the record, midterm exams are done, they're graded, the exam's been reviewed and all of that, and we'll pass them back this week in discussion section. The initial scoring, average score was about 64%, which is not bad, about right. The statistical analysis didn't reveal any technically bad items, but there were two items, numbers 9 and 10, that were kind of iffy by statistical standards. So I rescored those, giving everybody full credit for them, which jacked up the mean a couple of points. That was still a little low compared to the last time I taught this course, so to bring the averages for this semester up to the averages for the last time I taught the course, I added 5 points to everybody's score, truncating at 50. So you can't get a 55 on a 50-point test, right? So I didn't think anybody would object to that. And that's the distribution of scores, pretty good distribution. And as I say, we'll give those back to people in section today. Before I go on to talk about anesthesia, I want to pick up on some unfinished business from last time with respect to coma. And what you'll remember is that using brain imaging procedures, especially fMRI, some investigators, a group of investigators in Europe especially, have been able to detect signs of conscious activity in patients in their persistent vegetative state who are ostensibly unconscious. Remember that in the vegetative state, the patients don't show any behavioral signs of consciousness at all. But in this procedure, this group took a large number of subjects and simply presented them with various kinds of stimuli to look at their brain responses. And in one of these experiments, they actually asked unconscious patients to imagine hitting a ball on a tennis court or to imagine walking through a familiar building or whatever. And as you can see, there we go. What happened here was that some of these patients showed activity in brain regions that were also activated when normal controls were asked to perform the same kinds of tasks. That suggested to the investigators that these patients might have at least some minimal level of consciousness after all. But the thing I have to point out here just one more time is that this was a substantial minority of these patients. Tested 54 patients overall, roughly half vegetative patients, roughly half in this diagnosed with this new minimally conscious state, but only 5 of those patients, fewer than 10%, showed any signs of differential responsiveness. There have now been a number of these studies that have basically confirmed these results, which is first that some patients in the vegetative state, some patients in the so-called minimally conscious state do show these differential brain responses. Remember, they can't show any other kinds of responses because they're effectively paralyzed. But they do show brain activity that would, in ordinary individuals, suggest some level of consciousness. The next step here is to try to use this kind of methodology to actually communicate with these patients. And in fact, that's been done as well. Just going to skip over to one of these. This is a case study of a patient who had been in the vegetative state for a period of 5 years, and again was given these imagination tasks to perform. This is one of the 5 patients that I talked about earlier, but this time was asked to use these 2 differential tasks to answer yes/no questions. So, for example, she might be told, if the answer to my question is yes, then I want you to imagine playing tennis. If the answer to my question is no, then I want you to imagine moving around the house. And this particular patient was able to answer 5 yes or no questions accurately. These are questions about like personal details or family details. Do you have a brother named Donald or something like that? Yes or no? again, very striking evidence of some kind of conscious awareness in this patient who, as far as overt behavior was concerned, seemed to be unconscious and in a vegetative state. Yeah? They asked 5. And she did 5 out of 5, right? So that's pretty good. But again, 1 patient out of the 5 patients, I don't have that many fingers, 54 patients, out of all the thousands of patients that there are available. But still, it raises the possibility that for some individuals, it's possible to establish some kind of high-level communication with them. The importance of these studies, I think, there are really two aspects to focus on. The first is some patients who appear to be unconscious, not comatose, but in the vegetative state, some patients who appear to be unconscious, when they're tested carefully with the right kind of apparatus, show signs that in normal controls would be considered to be signs of conscious awareness. The second point here, I think, is actually more important, which is that one shouldn't conclude from a study like this that comatose patients are all conscious after all, right? That's not what the finding is. But as a kind of a corollary to this, consciousness is not necessarily well diagnosed just in terms of overt behavior. And what I think you're going to start seeing is more use of brain imaging to actually firm up a diagnosis of minimally conscious state. Right now, the criteria are kind of loose, but if you really want to differentiate those patients who are vegetative from those patients who are actually at least minimally conscious, something like this brain imaging technology is going to be very useful. So this is something that's just happening right now, as opposed to 100 years ago, and something that you're going to see more of in the future. Any questions about this before I go on? All right, so let's go on to the next thing here, which is anesthesia. And the connection here is that anesthesia is often often referred to by physicians as a kind of controlled coma. And chemical anesthesia for pain relief in the medicine and surgery is something that is relatively recent, hasn't been around all that long. Before the middle part of the 19th century, there really was nothing that surgeons or other physicians could do to help their patients gain some kind of control. If you had to have surgery, cancer surgery, leg amputated or something like that, basically you had to grin and bear it. You were asked to tolerate the pain. Sometimes you were loaded up with some alcohol. After opium came on the market, sometimes people were given opium, which doesn't really, in this preparation, didn't really relieve the pain, but made you feel a whole lot better about the surgery. The patients were physically restrained and sometimes given a piece of soft wood to bite down on, but that was basically it until the middle of the 19th century when in Boston, William T.G. Morton demonstrated the first successful application of ether as a chemical anesthetic. This is a big deal in the history of medicine. The first time that pain was brought under chemical control, such a big deal that there's a famous painting of it, which when you get to Harvard Medical School, if you go into the Countway Library, the big medical library there, you'll see it right there in the lobby. It's this humongous painting. These are actually this is Gilbert Abbott, who's the patient, and there's Morton, who's the person applying the ether, and J.C. Warren, who was a surgeon at Harvard Medical School, actually doing the surgery. It's one of these kind of narrative paintings that the 19th century was very famous for. We don't do it quite that way these days. General anesthesia in the clinic now, for those of you who have had it, is what's known as balanced anesthesia, because surgical patients are given a cocktail of different kinds of drugs, each of which has a different kind of effect. Patients are first given a sedative like the benzodiazepine, Librium or Valium type the drug, simply to relieve anxiety. And also, this sedative drug assists in the induction of anesthesia. Then they're given some other drug, which actually is the anesthetic agent and is intended to eliminate the conscious awareness. For Gilbert Abbott in 1846, it was ether. Ether is not used so much anymore, but usually one of two kinds of preparations, either an inhaled anesthetic that's delivered through a ventilator like isoflurane, or a narcotic anesthetic which is delivered intravenously. Patients are also given what's known in the surgical trade as a muscle relaxant. This is in fact a paralytic drug like curare. Many of them are in fact derived from curare, which is intended to calm the operative area so that you eliminate reflexive responses that makes the surgery difficult. And then the final element in this anesthetic cocktail is an analgesic agent. And you might say, well, if they're unconscious, why do they need an anesthetic? Why do they need an analgesic agent? Well, patients will vary in their level of anesthesia throughout a surgery, especially for a prolonged surgery. But especially this is given to control postoperative pain after the patient has recovered consciousness in the recovery room. So again, these days we usually, when we're doing anesthesia, we do what's known as a rapid sequence induction. The patients are given a barbiturate to very quickly induce anesthesia, and then often an inhaler is applied to deliver some gas like nitrous oxide mixed with oxygen that maintains the anesthesia throughout the surgery. Then you get the muscle relaxant, and then at the end, what they do is they give you another drug to counteract the curare-like drug to reverse the muscle relaxation. They remove the ventilator, you restore. Once you're not paralyzed any longer, you can breathe on your own, and then again they'll give you some kind of, typically a narcotic analgesic, to deal with postoperative pain. So again, what happens here is what surgeons, or anesthesiologists anyway, like to call a controlled coma. The patient is sedated, very calm. The patient has lost consciousness. They're not responsive during the surgery, and they don't have any memory for surgical events either. And also during the procedure, they are immobile. There's both a loss of voluntary motor behavior, which would occur because you're unconscious, but there's also a loss of involuntary reflexes as well by virtue of the muscle relaxant. Okay. When we start turning to research about on analgesia and anesthesia, again, if you think about this two-dimensional framework for thinking about consciousness, which is the way a lot of people like to think about consciousness, you've got this continuum of awareness on the one dimension, continuum of wakefulness on the other dimension, and general anesthesia tends to be located down here right next to coma, where the person is neither awake, neither aware nor awake of anything that's going on. I'm going to go very quickly over the mechanisms